Okay, welcome to our second installment of Chapter 21, our discussion of blood vessels and blood flow. And what you're looking at here is a contrast between an open vessel and a vessel with a constriction. And you can see that with a smaller diameter, what happens to the blood flow is that it becomes more turbulent, and the result is that the flow will tend to slow down. Whereas in a vessel that's wide open, because there's less contact between the fluid and the walls of the vessel, the flow is much quicker and a lot less turbulent as well. This is one of the reasons we worry about arteriosclerotic plaque building up in the walls of arteries. It narrows the vessels, causes turbulent flow, slows down blood flow, and can cause blood to clot. The rate of flow through a tube is expressed as the volume that passes a specific point per unit time. As an example, cardiac output at rest is 5 liters a minute. As a result, blood flow through the aorta is the same. Flow is equal to the difference in pressure divided by the resistance to that flow. P1 and P2 are pressures in the vessel at points 1 and 2, and R represents the resistance to the flow. So if you look at this equation, what you can see is that as resistance increases, flow decreases. Okay, so let's indicate that there. We'll go with red. All right. So we write this in the form of a fraction, makes it a little bit easier to see. You can indicate the difference between two pressures by the Greek letter delta. So delta P, the difference in pressure, divided by the resistance. Okay, is just another way of writing this expression. So you can see as the resistance increases, as the denominator gets bigger, what's going to happen is that the flow is going to slow down. As the difference in pressures increases, the flow is going to speed up. Okay? It's directly proportional to pressure differences and inversely proportional to resistance. Another form where V is the viscosity, that's the resistance to flow for the fluid. L is the length of the vessel. R is the radius of the vessel. Pi, of course, is 3.141. It's basically an irrational number. And D is the diameter of the vessel, and we raise that to the fourth power. Okay, Pucell's law is simply a relationship between viscosity, vessel length, and flow. Flow decreases when resistance increases and vice versa. Since resistance is proportional to blood vessel diameter, constriction of a blood vessel increases resistance and as a result is going to decrease the flow. So we can state this essentially as a restatement of our original equation, delta P over R is equal to flow. If we substitute in the expression that we saw in the previous slide, taking into account, again, diameter, resistance, length of the vessel, and viscosity, we generate this new statement of flow: pi times delta P times d to the fourth over 128 times the vessel length times the viscosity as a statement of the amount of flow. Remember that during exercise, the heart beats with more force to deliver more oxygen and nutrients to skeletal muscle to carry out activity, basically to pay the energy debt. And this results in increasing pressure in the aorta. Capillaries to the skeletal muscle increase in diameter, and this decreases resistance and increases the flow to the tissue. Increased flow in the aorta can go from 5 liters a minute to up to 25 liters a minute. So keep that in mind the next time you're exercising. Change. Viscosity is simply the measure of resistance of liquid to flow. So you could think of it in terms of the thickness of the liquid. The resistance is going to be proportionate to the flow. As viscosity increases, pressure is required to make it flow is going to increase as well. Think of a comparison between water and maple syrup. Okay, it's going to be tougher to move maple syrup through a tube than it would be to move water through a tube because the maple syrup has a much higher viscosity. The same is true with blood. Viscosity is influenced by your crit, and dehydration and uncontrolled production of red cells can often lead to increased viscosity, and this jacks up the workload on the heart and can lead to cardiomyopathy, which can, in some cases, lead to the heart failing. Okay, next thing we want to discuss is Laplace's law and compliance. The critical closing pressure is the pressure at which the blood vessel collapses and blood flow would then stop. Laplace's law indicates that the force acting on a blood vessel wall is proportional to the diameter of the vessel times the blood pressure. So the force is equal to the diameter times the pressure. As a result, as the diameter of the vessel increases, the force on the wall increases. The weakened part of a vessel wall bulges out and can produce what we know as an aneurysm, which could eventually rupture. Okay, so you can see here how these two things are tightly related. Okay, vascular compliance is the tendency for blood vessel volume to increase as blood pressure increases. Compliance is simply a measure of the increase in volume over the increase in pressure. The more easily the vessel wall stretches, the greater its compliance is going to be. The venous system has a large compliance. It's basically almost 20 times greater than that of the arteries, and as a result, it acts as a blood reservoir. Okay. Systemic circulation is going to be determined by the anatomical features of the circulatory system, the dynamics of blood flow, and the regulatory mechanisms that control the heart and the blood vessels, and these are both neuronal and hormonal. Blood volume occurs in all the vessels in the body. The veins have most of the blood at any point in time due to their high compliance. Smaller volumes are found in the arteries and the capillaries. And what you're looking at here is just a plot showing you the difference in the cross-sectional area compared to the amount of blood flow in terms of velocity as we move away from the heart and into the systemic tissues, and then eventually as we return back to the heart. So you can see from this diagram that as the diameter of the vessels decreases, the total cross-sectional area increases and the velocity of blood flow decreases. Only one aorta with a cross-sectional area of 5 square centimeters is where we're going to see a high velocity of blood flow and also, of course, a relatively wide diameter. The total cross-sectional area of millions of capillaries is about 2,500 square centimeters. So that's a significant amount of space and area to detour that the blood can take. So just like a stream that flows real quick through a narrow gorge but flows slowly through a broad plain, you can see the change in velocity as we head away from the heart. So velocity is relatively high here. Then as we increase the cross-sectional area, the velocity begins to drop, okay, for a couple of reasons. Number one, the vessels are getting tinier, the resistance is increasing, and the flow is beginning to slow. By the time we get to the capillaries, the flow is quite negligible, and then it begins to pick up as the capillaries empty into the venules, and the venules empty into the veins, and then the vena cava, of course, brings the blood back up to the heart. This is an interesting diagram because this is showing you how pressure overall decreases with increasing distance from the heart, and also how differences in pressure decrease with increasing distance from the heart. Blood pressure averages about 100 millimeters of mercury in the aorta and drops to 0 by the time the blood gets to the right atrium. This is due to decreased resistance to flow as the cross-sectional area goes way up. And remember, you can see the big drop here. Once we hit those capillary beds, we really shoot down big time in terms of pressure. The greatest drop in pressure occurs in the arterioles, which regulate blood flow through the tissues. You can think of the arterioles as doorways to the capillaries, and they control the amount of blood perfusing tissue at any particular time. There are no large fluctuations in capillaries and veins, and this is one of the reasons why you cannot take a pulse in a capillary or a vein, because you're unable to detect those tiny differences in pressure. Generally, when we take a pulse, we have to do it in areas of the body where arteries run relatively close to the surface and there's very little overlying fat and connective tissue. And so those are areas such as the carotids in the neck, the dorsalis pedis on the top of the foot, the inguinal region. Also, you can pick it up in the wrist, as you know. That's one of the most standard places to take a pulse, all right, and also in your temples. Muscular arteries and arterioles are capable of constricting or dilating in response to autonomic and hormonal stimulation. Muscular arteries are going to regulate flow into a region of the body, while the arterioles are going to regulate flow into a particular tissue. Okay, so bottom line is this is smooth muscle activity that's controlling this movement. Essentially, what's going on is that in conditions and tissues where we have low oxygen content, low nutrient content, or vice versa, buildup of waste products like CO2, what's going to happen is that we're going to perfuse those tissues in the systemic circulation, bring more blood into the area, deliver more oxygen and nutrients, and take away more waste products. Pulse pressure is the difference between systolic and diastolic pressure, and when we're talking about systolic and diastolic pressure here, we're referring primarily to the ventricles. It's true that the atria undergo systole and diastole, but the force they produce is so minor compared to the ventricles as to be negligible. It increases when stroke volume increases or vascular compliance decreases. Compliance tends to decrease with age as a result of conditions such as arteriosclerosis, and causes the pressure to rise as the arterial diameter shrinks. Pulse pressure can be used to take a pulse and determine heart rate and rhythmicity. The most frequent site used to measure the pulse rate is the carpus with the radial artery. We call this the radial pulse, but you can see here there's quite a few other places we can take a pulse. You can see up here in the superficial temporal and the carotids, here in the facial, the axillary artery under the arm, the brachial, the radial, the femoral, okay, the popliteal behind the knee, the dorsalis pedis, and the posterior tibial. Now you might ask, well, why so many areas to take a pulse? And the reason is the state of the patient, right? You might not be able to access certain pulse points depending on the patient's condition, and so you want to have alternative ways to generate a reading for pulse rate and a pulse pressure, and that's what these different locations provide for us. They're all areas of the body where arteries happen to be very close to the surface and there's not a lot of overlying tissue. As a result, if any of these areas are injured, there can be massive blood loss. In general, when you look at the outline of the body, what you tend to find is that veins tend to be deep, veins tend to be superficial, arteries tend to be deep, and this is essentially designed so that if we do get injured, if we have a puncture or laceration or an abrasion, when we bleed, we don't lose massive amounts of blood because the pressures are relatively low. This allows hemostasis to set up more effectively, and as a result, we don't hemorrhage as badly. If you've ever seen an artery nicked, you'll never forget it because the blood will spurt out and frequently hit the ceiling. It's very difficult to stop bleeding when you have a lacerated artery. Okay, next thing we want to touch on is capillary exchange and the regulation of interstitial fluid volume. Well, what is interstitial fluid, first of all? Interstitial fluid is the fluid between cells, okay? Capillaries are what bring the nutrients and the oxygen to the tissues so that they can generate ATP while whisking away the metabolic byproducts, carbon dioxide, urea, and ammonia. Okay? Capillary exchange is the movement of substances into and out of the capillaries. The most important means of exchange is diffusion. Remember that diffusion is the passive movement of substances from where they're most to least concentrated. Lipid-soluble substances can cross capillary walls by diffusing through the plasma membrane. Examples include oxygen molecules, carbon dioxide molecules, steroid hormones, and fatty acids. All of these have one thing in common: they are relatively non-polar, so they don't see the plasma membrane as a major energy barrier to movement. Water-soluble compounds have a different challenge. They diffuse through intercellular spaces or through fenestrations in the capillary. Examples include glucose and amino acids. Blood pressure, capillary permeability, and osmosis affect movement of fluid from the capillaries. Fluid moves out of capillaries at the arterial end, and most, but not all, returns to the capillaries at the venous end. Well, what happens to that remaining fluid? It enters the lymphatic system and eventually is screened by the lymph nodes for the presence of pathogens and cancer cells. The lymph nodes are basically collections of macrophages and lymphocytes. When the tissue fluids come into the lymph nodes as directed by the lymphatic vessels and capillaries, the flow through those organs slows down. The macrophages look for pathogens. If they see them, they engulf them and chop them up and display their molecules on the cell surface as a warning to the lymphocytes that we have a potential pathogen in the body that could cause disease. The result then is we select those lymphocytes that recognize those presented antigens, we amplify their numbers, and we create an army to go out and kill the invader. Okay? Once the interstitial fluid's been screened, it eventually returns to the general circulation at the right and left subclavian veins. So this is one of the body's ways of protecting us against disease, is by filtering out these pathogens in the event that they do make it through our non-specific defenses, which include our skin, our mucous membranes, and our granulocytes, as well as our secretions. Okay, net filtration pressure is simply the force responsible for moving fluid across the walls of the capillaries. There's two forces that affect it: hydrostatic pressure, which is simply the squeezing of the ventricles, which we call systole, and osmotic pressure, which is the movement of solutes in the presence of a non-diffusible solute, such as a long protein. Large proteins don't freely pass through the capillary walls, and the difference in protein concentration between the blood and the interstitial fluid is responsible for this movement of water. Net filtration pressure is equal to net hydrostatic pressure minus net osmotic. Net hydrostatic is equal to the blood pressure minus the interstitial filtration pressure. The osmotic pressure is equal to the blood colloid osmotic pressure minus the interstitial fluid osmotic pressure. So BP, blood pressure; IFP, interstitial fluid pressure; and BCOP, blood colloid osmotic; ICOP, interstitial fluid colloid osmotic pressure. So here's a look at fluid exchange across the walls of the capillaries. Okay, next topic we want to touch on is edema and capillary exchange. Remember that edema simply means an accumulation of fluid in the tissues. This is generally due to venous stasis. If the capillaries get more permeable, proteins can leak into the interstitial fluid, and this increases interstitial colloid osmotic pressure, resulting in more fluid moving from the capillaries into the interstitial fluid, resulting in a swelling of the tissue that we term edema. Chemicals of the inflammation process can increase permeability. We can also see a decrease in plasma concentration of protein that can reduce blood colloid osmotic pressure, and this causes more fluid to move out of the circulatory system and into the interstitium. Examples of where this happens include liver disease, resulting in essentially less plasma albumin. That's the main player in maintaining BCOP. Also, loss of plasma protein through the kidneys due to kidney damage or kidney disease, and lack of protein in the diet. Blockage of veins can also increase capillary blood pressure, and this will cause reduced venous return due to gravity. Remember that in order to get blood back to the heart, we have to occasionally move and breathe in order to overcome the effects of gravity. The veins have those valves that ensure one-way flow. As a result, the more active we are, the more venous return we have to the heart. Blockage or removal of a lymphatic vessel can result in massive tissue edema as well. Remember that 15% of the fluid that does not enter the venous return goes into the lymphatics. If we block those lymphatics, that fluid has nowhere to go, and it'll eventually accumulate in the tissues. Venous return to the heart increases due to an increase in blood volume, an increase in venous tone, and arterial dilation. Venous tone is just a continual state of partial contraction of the veins as a result of sympathetic stimulation. This is, again, smooth muscle activity. And the other thing we have to appreciate is that this is assisted by the skeletal muscle pump. Okay? In a standing position, hydrostatic pressure as a result of gravity increases blood pressure below the heart and decreases blood pressure above it. And in lab, you're going to actually investigate this when you take some blood pressures both standing and sitting. And what you'll find is that when you stand up, what happens is that the blood pressure in those vessels is going to increase. Muscular movement helps return more blood to the heart. They call this venous return. In addition to that, the fact that you're breathing helps to milk the inferior vena cava and bring more blood back up to the heart. So these are all important factors in improving venous return and improving, as a result, cardiac output. Okay, how do we control local blood flow to tissues? Well, you could probably guess a couple of the ways this is done. One is through simply an accumulation of carbon dioxide or a lack of oxygen. Another way, of course, is to change the pH of those tissues. As CO2 builds up, remember that it'll form carbonic acid. The carbonic acid, in turn, will dissociate into protons, and bicarbonate, it's the protons that will cause the pH to drop in those tissues. So all three of those can trigger an increase in perfusion in the systemic circulation. The nervous system is responsible for routing blood flow and maintaining blood pressure, but there's also hormonal control. Sympathetic potentials will stimulate the medulla to produce norepinephrine and epinephrine. That'll get dumped into the bloodstream. The result is that you're going to have more of that hormone flowing through your system, and we already know that one of the major effects of epinephrine is vasoconstriction. So what you're looking at here is just sort of a diagram showing you how the smooth muscle that is at the portals to these capillary beds, as well as the smooth muscle that's in the tunica media, can regulate blood flow. Here we see vasodilation of precapillary sphincters, which relax as tissue concentration of nutrients such as oxygen, glucose, amino acids, and fatty acids declines. The sphincters also relax as the concentration of vasodilating substances like carbon dioxide and lactate, adenosine and AMP and ADP, and nitric oxide and potassium increase, and also as the pH decreases. So most of these make intuitive sense, right? If you're accumulating too many waste products, we have to perfuse the tissue in order to wash them away. If you have a dearth of fuel and oxygen, we need to bring more blood into the area in order to supply the tissues with the nutrients and the oxygen they need. And so it's not a surprise that those are factors that tend to make the blood vessels open up. The nitric oxide and the AMP and the ADP, those are a little bit more arcane. They tend to be active primarily in inflammation scenarios where we have an injury or an infection and we want to bring blood to the area in an effort to try and knock out the bad guys and eventually affect tissue repair. On the right side of the diagram, you see constriction of precapillary sphincters in response to increased oxygen and glucose and amino and fatty acids. Makes sense, right? If you're fuel rich, you don't need more fuel. The sphincters also contract as the tissue concentration of byproducts like carbon dioxide, lactate, AMP, and ADP begin to decline. Okay, and again, this makes sense, right? The fewer waste products you have, the less circulation you need in order to wash those waste products away. The more fuel you have, the less blood flow you need. One of the things that we have to appreciate is that it's important to keep a constant blood flow to the tissues that need oxygen and nutrients, but at any one time, the majority of the capillary beds are actually closed off, and this is in part to maintain blood pressure. So what happens is the body sort of switches off which capillary beds are perfused and not from moment to moment. And priority again is governed by the accumulation or the diminishment of these important vasoactive substances. Blood flow can increase 7 to 8 times as a result of vasodilation of metaarterioles and precapillary sphincters in response to an increased metabolic rate. Vasomotion is simply the periodic contraction and relaxation of precapillary sphincters. We term this autoregulation. Long-term local control is also exerted. The capillaries become more dense in a region that has a regularly increased metabolic rate. An example, okay, muscle tissue. If you were to exercise, literally what would happen is that you would build more blood vessels to supply more oxygen and nutrients to the growing muscle because it needs more oxygen and nutrients in order to carry out its task. Another example, unfortunately, is cancer. Cancer is metastatic tissue. As it grows, it requires nutrients and oxygen, and so it'll send out chemicals that cause new blood vessels to grow into the expanding tumor mass and to nourish the tumor. Okay, nervous control of blood flow is also very important. Again, remember that all of these functions that go on to maintain homeostasis are governed primarily by the autonomic nervous system. So there is an important factor. We have to determine how the brainstem is going to interact with the ganglia and with the effectors in order to carry this out. So this is important in minute-to-minute regulation of local circulation. It provides a means by which blood can be shunted from one large area of the peripheral circulatory system to another by increasing resistance. The sympathetic division is the most important, and it innervates all vessels except for capillaries, which really don't have anything to innervate. There's not much smooth muscle there. Precapillary sphincters and metaarterioles are also left out of this control. Vasomotor centers are located in the lower pons and the upper medulla. The excitatory part is tonically active and it causes the vasomotor tone, and it's mediated by norepinephrine, and the inhibitory portion can cause vasodilation by decreasing sympathetic output. Sympathetic stimulation of the medulla causes more epinephrine and norepinephrine to be excreted into the blood, and this causes vasoconstriction in blood vessels via alpha adrenergic receptors, and not so much in skeletal muscle where vasodilation takes place as a result of interaction with beta adrenergic receptors. And this kind of makes sense, right? We want to provide blood flow to the muscle because the muscle is an integral part of the fight or flight response. And as a result, we want to enhance perfusion and perhaps shunt a little bit of blood away from less important tissues in response to a stress situation. Now, how do we regulate mean arterial pressure? Essentially, there are going to be hormonal and nervous regulatory mechanisms that are going to maintain mean arterial pressure, as well as local mechanisms. So we have to keep mean arterial pressure within a normal range of values, slightly less than the average of the systolic and diastolic on a moment-to-moment basis. And this is due to the fact that the average of the systolic and diastolic pressures causes diastole to last a little bit longer than systole. Okay, so there's a sort of a rebound effect there. Our mean arterial pressure is about 70 millimeters of mercury at birth, 100 millimeters of mercury from adolescence to middle age, and 110 in healthy older individuals. Your mean arterial pressure is calculated as your cardiac output times your peripheral resistance. It can also be calculated as your heart rate times your stroke volume times your peripheral resistance. Remember that CO is equal to HR times SV. If any of these contributing factors goes up, your heart rate, your stroke volume, your peripheral resistance, your mean arterial pressure is going to go up as well. And that just makes sense. And this is a good thing, but it's also a bad thing. If we were to increase peripheral resistance as a result, say, of arteriosclerosis or an increase in vessel length due to obesity, then what happens is that the mean arterial pressure will rise. This will increase the afterload on the heart and cause the heart to have to work harder to pump blood around the body. So two systems regulate pressure, short and long-term systems. Short-term regulation of blood pressure is via baroreceptors. They change peripheral resistance as well as heart rate and stroke volume in response to blood pressure changes. And then chemoreceptor reflexes, where we check the blood for its oxygen, CO2 content, and also its pH, and we adjust now the blood pressure accordingly. The central nervous system ischemic response results from high carbon dioxide or low pH levels in the medulla, and it's going to increase peripheral resistance. The result is going to be an increase in blood pressure. Okay, so let's take a look at how the baroreceptors operate. Okay, the adrenal medulla is a major player in maintaining blood pressure as well. Remember, the adrenal medulla, when innervated by the sympathetic division of the ANS, is going to release epinephrine and norepinephrine into the blood. What this is going to do to peripheral resistance is we'll see a substantial increase in sympathetic stimulation of the blood vessels, and we'll see a large decrease in blood pressure, or a sudden and substantial increase in physical activity or stress. All of these will trigger stimulation of the medulla. Adrenal glands are going to release epinephrine and norepinephrine in response to innervation, and these hormones are going to mimic the sympathetic stimulation of the heart and the blood vessels. So what's going to happen is your cardiac output's going to go up, okay, your heart rate's going to go up, and your stroke volume's going to go up. And in addition to that, we're going to see now an increase in vasoconstriction as well. So let's take a look at how the chemoreceptors control blood pressure. Okay, the effect of pH is one that you can probably tease out. Bottom line, okay, if your pH is dropping, that means CO2 is accumulating in the blood. The result is going to be an increase in heart rate and stroke volume, and the result is going to be an increase in blood pressure. On the flip side, if your pH rises, your oxygen content rises, your heart rate and your stroke volume are going to decline, and your blood pressure is going to go down. Okay, um, how is this going to be affected at the level of the vessels? Well, if we look here, okay, you can see if we start at the top of the Q, um, here we begin with blood pH increasing as a result of homeostasis being disturbed. Okay, so what's happening when your blood pH is increasing? Well, this is the result essentially of a loss of protons. All right, so chemoreceptors in the medulla are going to detect an increase in the blood pH. This is caused by a decrease in blood CO2. An increase in pH is going to inhibit the vasomotor and the cardioregulatory centers. Vasodilation is going to decrease peripheral resistance, and heart and stroke volume are going to drop. And the result is going to be decreased flow of the lungs, and this will increase your blood CO2 content, causing your pH to drop. On the flip side, if we look at blood pH decreasing, this means carbon dioxide is accumulating in the blood, causing production of carbonic acid, causing production of protons. The result is the blood pH begins to drop. So what do we have to do? We have to put the squeeze on the blood vessels, so we're going to have some vasoconstriction going on, and we're also going to jack up your heart rate and your stroke volume, so your cardiac output will go up. Okay, so a lot of these things you can kind of tease out yourself without actually having to memorize a bunch of different steps. Just think about what's happening when these disturbances in chemical homeostasis are taking place. Okay, the ischemic response is essentially a physiological reaction to a lack of blood flow. An elevation of blood pressure in response to a lack of blood flow to the medulla is what occurs, This functions in response to emergency situations if the blood pressure, say, falls below 50 millimeters of mercury. Neurons in the vasomotor center are stimulated. This increases blood flow to the brain if the vessels are intact, but at the same time, it decreases oxygenation of the blood because blood doesn't go to the lungs as effectively. Lack of oxygen causes vasomotor center to get inactive. We have extensive vasodilation following with a drop in blood pressure. Death will occur if the central nervous system ischemic response lasts longer than just a few minutes. Okay, so bottom line is this is a short-term reaction to an emergency situation. It has to be corrected. Generally, we're going to intervene in the event that this occurs. If we look at long-term regulation of blood pressure, we have to call into account um, the endocrine system and the urinary system, in addition to, of course, the cardiovascular system. The renin-angiotensin-aldosterone mechanism and the vasopressin mechanism, as well as ANP, are important players in regulating blood pressure. There's also a fluid shift mechanism and a stress relaxation response that we're going to address. So take a listen to the renin angiotensin aldosterone mechanism. Okay, and this will touch on the ADH mechanism. And what you're looking at here is simply, again, a an overview of what you just saw. Okay, you can see here the long-term control of blood pressure. Again, here we'll start with blood pressure increasing. So what we have to do is try and bring it down. Atrionatriuretic peptide um, is going to act on cardiac muscle cells. This will detect increased stretch in the atria, and we'll have secretion of ANP. What this will do is will hit the effectors. The blood vessels will vasodilate, peripheral resistance will drop, and the result is the blood pressure will drop and we'll head back down towards normal. The renin-angiotensin-aldosterone mechanism will respond by detecting the increased blood pressure. Um, we'll see production of angiotensin 2 and secretion of aldosterone from the adrenal cortex decrease, okay, because these are major players in bringing blood pressure back up. The effectors will carry out an assistive response by vasodilation, and the blood pressure will drop back down. On the flip side, okay, a little bit easier to understand, I think, if the blood pressure declines, we got to get the blood pressure back up. Renin-angiotensin-aldosterone mechanism is going to affect vasoconstriction and water retention. This will increase blood pressure and blood volume. Um, Aldosterone does this by retaining sodium, which as a byproduct causes you to retain more water. ADH, of course, directly acts on the kidney tubules to cause them to become less water permeable, um, or I'm sorry, more water permeable. So as a result, what happens is that you urinate concentrated urine, and the kidney holds on to more fluid. Okay, so essentially your blood volume and blood pressure are going to climb. Okay. Baroreceptors are also going to respond by increasing vasoconstriction, and this will jack up blood pressure, and the result then will be restore the original condition. Atrial natriuretic peptide is released from cardiac muscle tissue when the atrial blood pressure goes up. This is detected by atrial stretch. This stimulates an increase in urine production, and this decreases blood volume and blood pressure. The fluid shift response is the movement of fluid from the interstitial space into the capillaries in response to a drop in blood pressure to maintain blood volume, and vice versa. And then finally, the stress relaxation response is simply the adjustment of blood vessel smooth muscle to respond to changes in blood volume. When blood volume suddenly declines and pressure drops, smooth muscles will contract, and vice versa. Okay, that brings us to the end of Chapter 21. Again, review this material as it will be covered on our PRS quiz. And I'll see everybody in class.